Joining us now at ASH 2011 is Dr. and Professor Beppe Saglio, MD. He is here to discuss a follow-up of the Nilotinib versus Imatinib in patients with newly diagnosed Philadelphia chromosome-positive chronic myeloid leukemia in chronic phase, a follow-up of the ENESTnd study. Thanks for stopping by. That's a mouthful.
Thank you very much. Yes.
All right, so what was the objective or purpose of this follow-up?
Yes, the purpose was just to see the results of the ENESTnd study after 3 years of follow-up, because we know that in the comparative analysis, Nilotinib so far has demonstrated a great superiority in terms of deeper and faster responses with respect to Imatinib, but in terms of progression too. But of course, I would say the cutoff for the progression occurring also in Imatinib-treated patients in the previous high-risk study was after 3 years approximately. Therefore, it was very important to see, I would say, the stability and the significance of the results seen after 36 months of follow-up.
Based on the clinical data you've presented, what are the implications for practicing clinicians to take from it?
I would say for clinical physician is just the fact that the Nilotinib 300 mg twice a day harm is very well tolerated type of treatment for chronic phase CML patients, and it shows several advantages with respect to the Imatinib therapy. Not only I would say a faster and a deeper major molecular response, but also the fact that it is able not only to delay but to prevent a consistent number of progressions that may still occur on Imatinib therapy. Some cases of progression generally are concentrated within the first and second year, and indeed we didn't observe any new case during the third year follow-up in all the harms, but the number of progressions were significantly lower in the Nilotinib-treated patients with respect to what we have seen in the Imatinib-treated patients. And this translates in a really significant result, but even in considering the intention to treat analysis, just simply the fact that I want to treat a patient with one of the two drugs, there is still a significant difference in terms of rate of progression, in terms of risk of dying of the progression, because unfortunately even in our days progression is a fatal event in most of the patients, and in this aspect I would say the data that I've shown clearly demonstrate that the TKI therapy is very effective in chronic phase of the disease, is able to anticipate the progression, but once that the progression has occurred, has very, very little efficacy. And I would say 75 of the patients already died, and with a median overall survival of only 11 months. So these are impressive data.
What might be new on the horizon to impact your research and create better patient outcomes?
I would say that what we are looking with special interest at the moment, although is really highly investigational, is just also the possibility to discontinue the treatment. And we know from preliminary data of the French group that this is feasible for patients who are achieving a complete, so-called complete molecular response that now we prefer to graduate in a different way, but however substantially in what we can call complete molecular response, so the absence of detectable BCR boson transcript, and the patients who discontinue with a certain length of persistence in the complete molecular remission, they can resist in complete molecular resistance even after discontinuation in 40% of the cases. Being the percentage of the complete molecular remission much higher in the Nilotinib arms with respect to what we see in the Imatinib arm, we expect a quite high rate of possibilities and probabilities for the patients to discontinue the treatment.
Dr. Saglio, thanks for stopping by and sharing what you presented here at ASH. Best of luck to you in the future.
Thank you very much.
Okay, sir.